Hi, students. Welcome to our online lecture for this week, which is Module 5, Disorders of the Digestive System. Let's get to it. Before we get to patho stuff, let's just do a quick little review of some anatomy of the digestive system. Digestive system, we're talking about like the GI tract, the gastrointestinal tract, the upper GI tract, that would be the esophagus, stomach, and small intestines. And then the lower GI tract, that would be the large intestines and the anus. An important thing to keep in mind is the GI tract has a lot of sphincters, which a sphincter is just like a ring of muscle that opens and closes, and that helps control the like one directional movement of food as it's moving through the digestive system. Some sphincters that you should know for this module are the lower esophageal sphincter, which is the sphincter in between the esophagus and the stomach, and then also the pyloric sphincter, which is the sphincter in between the stomach and the small intestine. Both of those are important for some pathology that we're going to talk about in just a minute. Okay, so then just a little reminder about the stomach. The stomach itself is important for mechanical and chemical digestion. So mechanical digestion meaning actually like sort of like kneading the food, and then chemical digestion due to the acidic context of the stomach, as well as enzymes and things like that that help break down some of those macromolecules in food into smaller monomers. So the stomach itself is highly acidic, and that's due to hydrochloric acid, which is secreted by parietal cells, which are a type of cell in the stomach. And this whole reason the stomach is acidic is to help break down food. But of course, that could also break down the stomach itself, right? So the stomach has to protect itself from getting damaged by its own acid. And it does that by essentially having a nice thick lining of mucus all around its epithelium. And that mucus is created by a cell type called the gastric goblet cells. So just important to remember that the stomach is producing hydrochloric acid. That's a normal function of the stomach. And then also in a normal healthy stomach, there's a layer of mucus to protect the inner lining of the stomach from that acid itself. Okay, and then next up, we have the small intestine. So after food leaves the stomach, it would go into the small intestine. Most absorption, so absorption of nutrients and vitamins and things like that, that mostly happens in the small intestine. And knowing that, it makes sense that the small intestine has a lot of villi, which are sort of like this finger-like projection of the lining of the small intestine that just increases the surface area of the small intestine. So there's more surface area for absorption. And then if you zoomed in even closer on these epithelial cells that are lining the small intestine, you would see that those cells themselves have little tiny villi on top of them. There's called microvilli that just increases the surface area even more. So it's like double layers of villi. There are 3 regions of the small intestine, just good to remind yourself of these words. So the first region, which comes right after the stomach, is the duodenum or the duodenum. I will probably say it both ways. I've always said duodenum, but sometimes I say duodenum. For all I know, they're both right. Tomato, right? After the duodenum is the jejunum, and then finally the ileum. In terms of what is happening in each region, for what you need to know, the most important thing to remember is just like the order of those regions of the small intestine, and specifically that the duodenum comes right after the stomach. That's important to remember. Okay, and then finally, food will move into the large intestine or the colon. The purpose of the large intestine is to mostly absorb water. So it's going to make sure that the feces are not too watery and reabsorb water back into the circulation. And then, of course, it also stores feces until defecation. So there's our little fun walkthrough of food through the digestive system. But then, of course, there's also a lot of accessory organs that are important in the digestive system. So these are organs that food doesn't directly pass through these organs, but they are essential for digestion because they make enzymes and other things that are important for digestion. So the first very important accessory organ is the liver, and that is because the liver makes bile. Bile is important for digesting fats or absorbing fats. The liver does a lot of other things as well too, but in terms of this unit, when we're talking about sort of like digestion, we're mostly going to think about the liver making bile as like its primary function. And then the gallbladder, that stores and concentrates bile that comes from the liver. So the liver makes the bile, sends it to the gallbladder, and the gallbladder stores it. And then we have the pancreas, which synthesizes and secretes digestive enzymes. That would be the exocrine function of the pancreas is secreting these digestive enzymes. The pancreas also has endocrine functions because it secretes some other hormones like insulin and glucagon. Once again, we will not be talking about those functions of the pancreas this week. So for this week, it's just the digestive function of the pancreas, which is making those digestive enzymes. All right, and then like I said, the liver secretes bile. It's going to be really important to remember what bile is for this unit because a lot of digestive system dysfunction somehow has something to do with bile. So bile aids in digestion and absorption of fats. So I hope you remember from biology and or chemistry that fats are hydrophobic, meaning that they're mostly nonpolar. They do not mix well with water. They are water insoluble. So since you are mostly made of water, it's actually really hard for those fats to go from your digestive system into your bloodstream and then to get delivered all over your body. So really the only way that can happen is if those fats are solubilized somehow in these little, like micelles, these little fat droplets. And so that's what bile salts do. They essentially form a little coating around those lipid droplets so that they're more easily absorbed. Bile is also important for excretion of certain molecules like bilirubin. Oh, we're coming back to bilirubin again, which remember is a breakdown product of hemoglobin. So bile itself is made of bile salts. Those are the parts that actually have sort of this ability to like coat the fat droplet and have like a hydrophobic and a hydrophilic side. They also contain phospholipids, cholesterol, and then bile pigments, which would be bilirubin. Bile is synthesized in the liver by hepatocytes, which are a type of cell in the liver. And importantly, without bile, those lipids are not going to get digested and absorbed, which means they're just going to be excreted in the feces. And then you'll end up having staturia, which is fatty stools. So sort of like loose, light colored stools because there's too much fat in the stools. Okay. And just a reminder of how bile gets from the liver into the intestines. So once again, bile is made in the liver, and then the hepatic ducts carry that bile out of the liver and into the gallbladder. Sorry, the hepatic ducts carry the bile to the cystic duct, which then carries the bile into the gallbladder. So you have like sort of this little branching from the hepatic ducts into the cystic duct. And then that bile can then go out of the gallbladder into the small intestine, into the duodenum, and that happens by going through the common bile duct. So sort of like important, well, all three of these are important to remember, but the hepatic duct, that's easy to remember, hepatic, liver, that's the one that's coming directly from the liver. And then the common bile duct, I remember that it's common because sort of like both of these branches eventually drain into the common bile duct. You might also be able to remember that this is like the most important duct that goes into the small intestines because it is possible for people to exist without a gallbladder. Lots of people get their gallbladder removed and it's fine. And that's because the liver is what's actually making bile. And so that bile that's made by the liver can just go straight from the hepatic duct into the common bile duct if someone does not have a gallbladder. So that helps me remember sort of like the flow of bile through all those different ducts. Okay, fantastic. So there's a little anatomy review for us before we hop into all of the different pathophysiology of these different diseases and disorders. Okay, so we're going to start with disorders of the esophagus and just kind of work our way slowly down the digestive system. So the esophagus normally propels food into the stomach. So the esophagus has this like typical movement called peristalsis, which is contraction, like a rhythmic contraction of muscles in the esophagus, which helps sort of push that food all the way down into the stomach. So if you have disorders of the esophagus, essentially you're going to have trouble having that food move down so that you're going to have trouble swallowing for the most part. Most of the causes of esophageal disorders would be inflammation, obstruction. So you could have like a tumor or something that's pressing against the esophagus, or a lot of times neuromuscular issues because there's autonomic innervation of the esophagus a lot of the time to control that peristalsis. So if there's something wrong with that innervation, then that's going to cause esophageal disorders. Some common signs and symptoms in general of esophageal disorders would be dysphagia, which is difficulty swallowing. um, adenophagia, which is painful swallowing, and then regurgitation, which is when undigested food and gastric acid from the stomach go back up into the mouth. So those are your classic esophageal signs and symptoms. Okay, so the first disorder that you need to know about the esophagus is achalasia. So this would just be like a general problem with esophageal motility, meaning that for some reason things are just not moving. So like food is just not moving through the esophagus. That is usually because the lower esophageal sphincter, which once again is that like muscular ring that separates the esophagus from the stomach, um, that esophageal sphincter usually is just not relaxing. So it's like stuck closed all the time. So you can imagine you would get food sort of like stuck right there at the end of the esophagus. So this is often unknown why this happens. It's actually very rare, but it could be due to Chagas disease or due to a malignancy. Once again, maybe like a tumor pressing up here against that sphincter. So this would present with dysphagia, so trouble swallowing, regurgitation, and chest pain, because as I would imagine, having a bolus of food stuck right there against that sphincter would probably be painful. Okay, a much more common esophageal disorder is GERD or gastroesophageal reflux disease. We've already talked about this a little bit in this class, so we're not going to go into it in too much depth today, but just a reminder of what this is. So normally, once again, you have that lower esophageal sphincter that separates the stomach from the esophagus. And remember, the stomach is very acidic, but the stomach has that lining of mucus to protect the stomach from that very acidic environment, so the stomach doesn't get damaged. In GERD, what happens is some of those stomach contents go up through like the wrong way through the esophageal sphincter. So in other words, there's reflux of those stomach contents. Because the stomach contents are acidic, that's going to present with heartburn or pyrosis, which is like a very burning substernal, meaning behind the breastbone pain. If you've ever had heartburn, it's not fun. It's very painful, and like it really does feel like your heart is burning. It feels like acid burning your esophagus. That's exactly what it sounds like. Um, Also regurgitation, once again, because of those stomach contents coming back up through that lower esophageal sphincter. Dysphagia because of just the inability of that sphincter to work properly. And then people who have repeated GERD, sometimes there can actually be aspiration of those stomach contents into the lungs. And that can cause like a chronic cough and hoarseness and issues like that because of that aspiration. Some risk factors that can make someone more susceptible to developing GERD is anything that weakens the lower esophageal sphincter. So that could be obesity, a fat-rich diet, caffeine, and alcohol. Also, some medications like antihistamines and a hiatal hernia, which we'll talk about in just a moment, which is essentially when the stomach slides up through an opening in the diaphragm. And because of that, it's just like kind of squeezing the stomach against that lower esophageal sphincter, and that makes it more likely to reflux up through that sphincter. And then, of course, we've talked about this once or already, but just touching on this again. Chronic GERD, so if this keeps happening, you keep having this reflux, you can have this sign called Barrett's esophagus. So this is metaplasia of cells in the lower esophagus. So metaplasia meaning the cell type switches from one cell type to another cell type. So normally the cells in the esophagus should be esophagus cells or squamous esophagus cells. But in Barrett's esophagus, what happens is because of that repeated acid that keeps getting pounded onto those cells, they almost have like a compensatory change to become a different type of cell. So they become stomach columnar epithelium cells, which are more resistant to the acid. So it like makes sense from those cells' point of view why they kind of want to switch to a different cell type to protect themselves from that acid. But the downside is once that's happened, those cells are actually more at risk to become cancer because in general, if cells are switching from one cell type to another, that's sort of a dangerous game that puts them potentially down the road to becoming cancer in the future. So, okay, so GERD, there we go, stomach acid flowing up back through that lower esophageal sphincter. And that takes us through all of the esophageal disorders that you need to know. Okay, Next up, disorders of the stomach and small intestine. So we're going to start with hernias. So a hernia is just when an organ pushes through the muscle or tissue that usually contains it. Um, Usually, when we use the word hernia, we specifically mean intestinal hernias pushing through the weakened abdominal muscles. But there is, sorry, I thought that was my dog. There's also, like I mentioned before, that hernia where the stomach and the esophagus pushes up through the diaphragm. So let's actually, I'm going to watch it, or I'm going to have you guys watch this video because I like this animation. I think it helps you visualize what is happening in this hernia. So let's go ahead and just watch this ever so quickly together.
Your esophagus, the pipe that goes from your mouth to your stomach, passes into your stomach through a hole or hiatus in your diaphragm. Normally, the stomach is situated completely below the diaphragm, as shown here. The esophageal sphincter acts like a one-way valve to stop the acid that's produced in your stomach to break down food from flowing up into your esophagus. Here we show the valve opening and closing. In a sliding hiatus hernia, the sphincter and the top part of the stomach push upwards into the chest. A hiatus hernia can prevent the esophageal sphincter from closing properly. If this happens, acid from the stomach can pass into the esophagus and cause discomfort, known as heartburn. However, often hiatus hernias don't cause any symptoms. Sliding hiatus hernias are usually quite small. They can slide back and forth through the hiatus, so symptoms can come and go. Sometimes sliding and rolling hiatus hernias are present at the same time. This is known as a mixed hernia.
Okay, there you go. So I like that little video because I think it does a nice job of showing you what it means by a sliding hernia. So the stomach and the esophagus are sliding up through that little opening in the diaphragm, which is a natural opening, but naturally it should be quite small. So in this sliding hernia, it's like the opening's gotten too big, and so the stomach and the esophagus are sliding up through that opening. But then it can also slide back down. So if someone is standing up, usually the hernia is back in place, but if they lay down, it might slide out. So a lot of times there's no symptoms besides just GERD. They mentioned the video of one other type of hernia, which is a rolling hernia. So that would actually be more like the fundus, just the very top of the stomach is like permanently through that opening. And those are much more rare, but they can have more symptoms if there is like strangulation of the hernia, which we'll talk in a second about what that means. So signs and symptoms here would be largely due to GERD, so things like retrosternal, so that behind the breastbone heartburn, dysphagia, and belching. Nope, don't play the video yet. We already played it. Great. Okay, so I mentioned that most hernias, when we talk about hernias, we're usually talking about intestinal hernias. That last example was talking about stomach hernias. So an intestinal hernia would be protrusion of a section of the small intestine through a weakened abdominal wall muscle. Most commonly, you have these hernias that are more common in males, where you have the intestines moving through this part in the inner thigh, the inguinal canal. That's because that is where the testicles descend from. Usually, these are more common in young males, like in babies. But because of that, just anatomically, there's a weakening in the abdominal wall there in males, so they are more likely to have like this specific type of hernia. You can also have hernias in many other places, like umbilical hernias, which are from the belly button. If there's some sort of surgery, then you could have a hernia out of the surgical incision, things like that. So regardless of the type of hernia, if it's intestinal, if it's not, it doesn't matter where it is, we can sort of talk about how severe the hernia is based on these three different categories. So a reducible hernia is the least severe type. This would be a hernia where you can manually just kind of pop the intestines back into place. An incarcerated hernia would be now the intestines, you can't pop them back in. They're actually kind of embedded in those muscle fibers, so it's permanently stuck out. And then a strangulated hernia would be when you have one of those incarcerated hernias that is permanently stuck out, but it is stuck out in a way that the blood supply is starting to get cut off to the to the incarcerated hernia. So it's strangling it. So that is going to eventually cause ischemia and pain. And if it went on long enough, that it could cause necrosis. Okay, so that's hernias. Moving on to peptic ulcer disease or PUD. So an ulcer is just like a sore. So a peptic ulcer would be a sore in either the stomach, so those would be gastric ulcers, or in the duodenum, which would be duodenal ulcers. Uh, Normally, like I said before, the mucus in the stomach protects epithelial cells from that stomach acid. So normally, even though the stomach is very acidic, the cells in the stomach don't mind that, they handle it just fine. But what happens in peptic ulcer disease is, for reasons we'll talk about in a second, that mucous membrane becomes eroded. And so now that acid has access to those epithelial cells and is going to cause inflammation and damage to those cells. So signs and symptoms are epigastric pain, pain that is worse between meals, so usually 2 to 3 hours after eating. That kind of makes sense because when the stomach is full and there's more stomach contents, it's kind of like dilute out some of that acid. But between meals, when the stomach is empty and you're starting to build up more acid in the stomach, then it's going to worsen the symptoms. Blood in the vomit, so hematoemesis, and melena, which is black tarry stools. So those would both be because of more serious ulcers that are starting to bleed. So what are some causes of peptic ulcer disease? The most common cause and the biggest risk factor is infection with H. pylori, which is a bacterial infection, Helicobacter pylori. So this is a bacteria that a lot of people have, and for reasons we don't totally understand, in some people, it causes peptic ulcer disease. For other people, they can have this bacterial infection and be totally fine. It just like hangs out in your stomach all the time and doesn't seem to do anything. But in other people, it contributes to peptic ulcers. So the way that works is this bacteria secretes an enzyme called urase. Because the bacteria is living in the stomach, which is super duper acidic, right? It's so acidic that it would kill that bacteria. So the way that the bacteria deals with that is by secreting this enzyme called urase. And so what this enzyme does is urase breaks down urea and makes ammonia and CO2. And that ammonia can actually neutralize the acid in the stomach. So it's almost like the bacteria is making a little zone of protection for itself with this enzyme urase by just essentially neutralizing the acid around wherever it is. So that's a good thing for the bacteria, but not a such great thing for your stomach, because that ammonia that is a byproduct of this bacteria, that ammonia that's produced can be toxic to these gastric epithelial cells and cause them to become inflamed, and then they're not going to produce as much mucosa, and then you're going to have some damage, just like you can see here, because of that buildup of stomach acid that's damaging the epithelial cells. Fun fact about H. pylori: when the scientist who figured this out first thought that there was a bacteria that was causative for peptic ulcer disease, a lot of people didn't believe him. So he just drank like a whole bunch of H. pylori, and then he got ulcers. And he was like, see, I told you. So I always like those stories when scientists have to prove to people their findings by doing crazy things like drinking a whole vat of bacteria. So, anyway, so how usually if there is a suspicion of peptic ulcer disease, there will need to be testing for H. pylori, because most people have H. pylori infections if they have peptic ulcer disease, and you need to treat the H. pylori infection with antibiotics in order to resolve the peptic ulcer disease. Because if you just treat the symptoms, then it's just going to keep coming back. So testing for H. pylori infection, you can look for anti-H. pylori antibodies in the blood. So these are antibodies that recognize specifically that bacteria. You can also look for antigens from H. pylori in the feces. So antigens, once again, meaning like the proteins that are from the bacteria themselves. So if you see those bacterial proteins in the feces, then quite obviously that person has the H. pylori infection. And then you can also do something called a urea breath test. This is less commonly done, but essentially someone takes radioactive urea And then you wait a little bit and see how much of that urea gets broken down. And if you see an increase in urea breakdown, that is indicative of this bacterial infection since they have this urease enzyme that breaks down urea. All right, so that's H. pylori, which once again is the biggest risk factor for developing peptic ulcer disease. Another big risk factor is NSAIDs use. So NSAIDs are non-steroidal anti-inflammatory drugs. That would be things like aspirin, although usually when we say aspirin, we don't mean that to be NSAIDs, but they work the same way. So aspirin, ibuprofen, like naproxen, all those types of things. So the way that these drugs work is they inhibit the enzymes called cyclooxygenase 1 and 2, or COX enzymes, and these enzymes make prostaglandins. And prostaglandins do a lot of things in your body. One of the big things they do is elicit pain and inflammation and fever. So that is why you can take NSAIDs to treat pain. That's why they're anti-inflammatories. That's why they also help reduce fever. So NSAIDs are good in all of that way. But those cyclooxygenase enzymes also make prostaglandins that are really important for production of that gastric mucosa. So if you were taking NSAIDs, then you were also blocking that action of those COX enzymes, and you'll actually end up decreasing the amount of mucosa in the stomach. So with chronic NSAID use, so people who are taking NSAIDs like every day, that can make them more at risk for developing peptic ulcer disease. So this would be oftentimes someone who's taking like baby aspirin every day to prevent like blood clotting or any sort of platelet activation. So if that is what happens, then you have to maybe consider switching to a different type of NSAID that only blocks COX-2, as opposed to these non-specific NSAIDs that block both of those enzymes. So, okay, so that's peptic ulcer disease. So moving on. Next up, we have gastroenteritis. So this is just irritation of the lining of the stomach, small or large intestines. This can be due to pathogens or toxins, but most commonly it is due to pathogens. This is essentially if you have ever had, quote, the stomach flu, you have had gastroenteritis, and I'm sure we all have at some point in our life. So that would be things like norovirus, rotavirus, E. coli, C. diff. These are all things that cause gastroenteritis. Signs and symptoms, just think all the horrible signs and symptoms of stomach flu. So that would be like nausea, vomiting, abdominal cramping, diarrhea, and high-pitched bowel sounds. So gastroenteritis causes, or one of the signs and symptoms is diarrhea, and that's caused by fluid shift into the intestines, into the point where that fluid can no longer be absorbed, so it becomes diarrhea. So in other words, there's just too much liquid in the intestines, and the intestines can't reabsorb that liquid, so it's got to come out. In terms of, there's a lot of different ways that diarrhea can happen, but in terms of gastroenteritis, there's essentially two mechanisms. So there's inflammatory diarrhea, so that could be because there is damage to the mucosal lining of the intestines because of some pathogen causing inflammation within the intestines. So that can cause diarrhea because as the mucosa becomes inflamed, it's just unable to reabsorb those fluids as effectively. Or I find this very interesting, you can have secretory diarrhea. So that is what happens in cholera, someone who has cholera. So essentially, cholera is caused by this bacteria that releases a toxin. And this toxin essentially has, through a complicated signaling pathway that we're not going to go through, eventually causes the cells lining the intestines to secrete a bunch of ions. So they'll secrete sodium and potassium and chloride and bicarbonate. And as I'm sure you remember from biology, as those ions move out, water is going to follow them. So you're increasing the amount of water and electrolytes that are secreted out of those cells, and they go into the intestines, and that causes like really horrible diarrhea. So just a little information about how gastroenteritis can cause that fluid shift, which contributes to diarrhea. Okay. And then our last stomach, small intestine disease and disorder is celiac disease. So celiac disease is a hypersensitivity to gluten. So this would be an immune disorder as well as a digestive system disorder. So there is a specific peptide in gluten called gliadin. And for reasons we don't really understand, in some people, there is a hypersensitivity reaction to that specific peptide. And because of that, you have inflammation that destroys intestinal villi. So the whole point of the villi is to increase surface area so that you can have absorption. But if those villi are destroyed, then you have less surface area for absorption. So you're going to impair absorption of nutrients, electrolytes, all those things. So a lot of the signs and symptoms of celiac disease are largely due to that decreased nutrient absorption. So bloating, diarrhea, because once again, you can't absorb liquids as much, muscle wasting because you're not able to absorb like proteins and amino acids. So your body is having a hard time building and regenerating muscles. I don't know. Steatorrhea, I did it. Steatorrhea, which is fat in the stools. So that is because of this loss of microvilli, there is decrease in the ability to absorb fat, and so that fat is lost in the stools. And then vitamin deficiencies, because a lot of vitamins are absorbed in the intestines. So, for example, you'll have like a decrease in B12 absorption, which can cause precocious anemia. You can have a decrease in absorption of vitamin K, which can lead to clotting disorders. So you can have a lot of signs and symptoms all related to that decreased nutrient absorption. It is worth noting that a lot of people who feel that they have like gluten sensitivity, that's not necessarily celiac disease. So celiac disease is like a very specific, very like harmful and serious hypersensitivity. So also an immune dysfunction. And some people also just might have like a mild like allergy or just like inability to digest gluten as well. And so they can take gluten out of their diet and feel a lot better. But that is not necessarily celiac disease because they're not having like all of these very serious signs and symptoms. So just so you know. Okay. So that is stomach and small intestine. We are flying. We're going to move right into disorders of the large intestine. So the first disorder for the large intestine is inflammatory bowel disease, or IBD. It is worth noting that this is different than IBS, which is inflammatory bowel syndrome. So inflammatory bowel syndrome might have some similar signs and symptoms, so like abdominal pain, constipation, diarrhea, things like that, but there's no pathological changes within the bowel itself. So it's different than IBD. IBD, on the other hand, you have like very specific changes to the bowel. And so because of that, we like are more clear on the etiology of IBD. It's caused by essentially two different disorders. So one is ulcerative colitis, or UC, and the other is Crohn's disease. So these are the two causes of inflammatory bowel disease. So once again, the signs and symptoms though are severe abdominal pain, diarrhea, bloody stools, and weight loss. And that weight loss can be related to decreased absorption of nutrients because of the damage to the bowels. Okay, so the first type of inflammatory bowel disease is UC, or ulcerative colitis. This is the most common form of IBD. It is unknown exactly why someone would develop UC, but it does seem to be that there is a genetic component. If you have a first-degree relative who has UC, it makes you more likely to also be diagnosed with UC. Importantly, one thing you're getting to understand is the difference between UC and Crohn's disease. So one of the big differences is that UC only affects the colon. So it only infects the large intestine. And it also, unfortunately, predisposes people who have UC to colon cancer later in life. And the characteristic finding you would see on someone after a colonoscopy, which is really the only way you can tell the difference between UC and Crohn's disease, is by doing a colonoscopy and biopsy. So the characteristic finding you would find with someone with UC is something called pseudopolyps, which are these like little tiny polyp-looking structures within the colon that are due to granulation or due to like increased fibrosis within the that tissue within the You would also see continuous inflammation throughout the colon. So, like, really, the whole colon is going to be pretty affected. And generally, in people with UC, the damage to the mucosa can be really extensive, to the point that the colonoscopy itself can actually cause some damage as the colonoscopy is occurring. And so you might see bleeding and have bleeding as a result of that colonoscopy. So that is UC. Compared to Crohn's disease. So Crohn's disease is a little bit different in that it can affect any part of the GI tract, not just the colon. So you can have Crohn's disease lesions all the way in the mouth down to the anus. So it's really the entire GI tract. That being said, they are most commonly located in the terminal ileum, so the last part of the small intestine, and the right ascending colon. Just like you see, the etiology is unknown, but there's certainly a genetic and environmental factors that contribute to development of Crohn's disease. And then on colonoscopy, the characteristic findings that you would see that would help for the diagnosis of Crohn's disease would be skip lesions. So skip lesions are patches of damaged tissue interspersed with healthy tissue. So they're lesions that skip. It's not just like one big piece of damage, it's regions of damage. And then you also might see this cobblestone appearance, which is just because of the damage that's happening in Crohn's disease. The tissue will look kind of like rounded, like a cobblestone. So those are the two classic signs of Crohn's disease. And then this is in the slides. I'm not going to talk through all this, but this is just like a side-by-side comparison of Crohn's disease and ulcerative colitis. Once again, UC is only the rectum and the colon, whereas Crohn's disease can be any part of the GI tract. Those are like one of the most important differences there. And then the other really important difference are those findings on the colonoscopy. So Crohn's disease, you would see those skip lesions and the cobblestone appearance, whereas in ulcerative colitis, you would not see those things, and you might see those pseudopolyps instead. Okay, so that is inflammatory bowel disease. Moving right along. We are going to move to the next topic, which is diverticular disease. So diverticulosis is when the bowel wall has weakened and you get these little outpouchings. So this is a nice picture. So this is what the normal bowel should look like. So just, nice and smooth and like well-defined, but a little outpouching, like a little pooch that comes out, that is called a diverticula. So it's almost like a little pocket that forms along the bowel, so along the large intestine. The bad thing about that is I'm sure you can imagine that it's possible that intestinal contents can get stuck in that little pocket, and that can form obstructions, it can form inflammation. So if you get inflammation within those diverticula, that's called diverticulitis. So anytime you see that starting word diverticular, you want to think of those little pockets that are forming along the bowel. The biggest risk factor here are diets that are low in fiber, because fiber just helps things move through the large intestine more efficiently. So low in fiber is going to kind of just cause more strain on the large intestine, which can make it more likely that you'll get those little pockets forming. Signs and symptoms of diverticular disease would be left quadrant or mid-abdominal pain, acute lower abdominal pain, and alterations in bowel habits. So that could be bouts of constipation and or diarrhea. Okay, and then next, we're fine. We're doing, like I said, I'm trying to get us to an hour. Next up, we have appendicitis. So the appendix is like a little vestigial, although maybe not as vestigial as we thought it was, but probably vestigial organ that's like right at the start of the large intestine. Appendicitis is inflammation of the appendix that's usually due to a blockage in the appendix that becomes infected. Treatment of appendicitis is usually surgical removal of the appendix, which is called an appendectomy. There are some very characteristic signs and symptoms of appendicitis. So the biggest one is right lower quadrant pain, and specifically rebound tenderness, meaning that in that right lower quadrant, if you push on it and then let it go, that like letting it go moment will actually hurt a lot more than just pushing it in. I had appendicitis. I don't know if any of you had as well, and that is what made me go to the emergency room is I had a lot of pain, but then, I just thought it was like cramps or something. But then when I pushed on my right lower quadrant and then I had that rebound tenderness, I was like, ooh, yeah, that hurt a lot more. Maybe we should go to the emergency room. Maybe it's appendicitis. And it was. So rebound tenderness is like the classic, but then once again, also that right lower quadrant pain is also classically indicative of appendicitis. Okay. Oh, I lied. We have two more. Two more? Three more? Two more. Okay. So next up we have volvulus, which is a twisting of the large intestine around a point of attachment. So essentially this is like the large intestine just gets wrapped up and twisted around something within the abdomen. This is more common in infants. Usually it's like a birth defect or something that a baby is born with. And usually this has to require a surgical fix in order to fix that. All right, and then last thing are hemorrhoids. So hemorrhoids are dilated, swollen blood vessels in the lower rectum. Hemorrhoids are pretty common. It's estimated a little under 5%, but it's probably more than that because a lot of people probably just self-treat at home with over-the-counter topical ointments like Preparation H. The biggest risk factors for developing hemorrhoids are going to be anything that decrease venous return because since they're swollen blood vessels like veins, anything that prevents that blood from getting moved out of those veins is going to increase the likelihood of hemorrhoids. So that would include varicose veins within the perianal region, straining during defecation, just because that can put some strain on those veins themselves. Anal intercourse, because that can cause just some trauma within the region. Pregnancy and also prolonged sitting. Pregnancy because you're causing a lot of pressure, and then prolonged sitting because you're just having blood pooling within the perianal region. Signs and symptoms of hemorrhoids would include itching, bleeding, and then bright red blood and stool. So the bright red part is important because that tells you that the blood hasn't had time to be digested. So it must be fairly close to the end of the digestive tract, as opposed to before when we talked about the black tarry stools. The black tarry stools are due to blood that has been digested, so it's gone further through the digestive tract. Okay. Whew. So that was stomach, small intestine, large intestine. We're flying. All right, now we're on to the accessory organs of the digestive system. So next up will be disorders of the liver. So liver cirrhosis, which can be a consequence of other liver disorders, but liver cirrhosis is essentially scarring and damage of the liver, resulting in fibrosis and dysfunction. Usually liver cirrhosis is irreversible, so this tends to be thought of as like end-stage liver disease is when liver cirrhosis is happening because you're having that irreversible damage. Because of the cirrhosis in the liver, you can end up having portal vein hypertension, which leads to ascites, which is just excess fluid in the peritoneum. That's because similar to when we were talking about heart failure, anytime you have an increase in blood pressure in a region, that's going to cause fluid to leave the vasculature in that region. So that is why you get ascites, because you're having an increase in blood pressure, which makes fluid leave the vasculature and go into this case, into the peritoneum. So the liver makes bile. And as I said way back at the start, bile is really important for binding to bilirubin and like helping us excrete bilirubin. So when bilirubin is bound to bile, it's called conjugated bilirubin. So if the liver is not functioning properly, then you will have a decrease in conjugation of bilirubin. So that is going to cause jaundice because you won't be able to excrete and get rid of that bilirubin. Okay, so lots of things can cause liver cirrhosis, including like alcoholism, but also sort of late stage hepatitis. So hepatitis is an infection involving the liver. Chronic hepatitis would be if you have inflammation and necrosis of the liver that lasts for 6 months or longer. That chronic hepatitis is most likely due to hepatitis C virus. 40% of all chronic hepatitis cases are due to hep C. And that is just going to predispose that person to eventually develop cirrhosis and or liver cancer. So signs and symptoms of hepatitis, jaundice for the same reason as I mentioned before. If the liver is not working properly, then you're going to have trouble excreting bilirubin. Dark urine, which is also due to bilirubin, light-colored stools, fever, fatigue, and abdominal pain. So there are 5 different types of hepatitis viruses. They're not necessarily all in like the same family or anything like that. They're just all called hepatitis viruses because they're able of infecting the liver. For the most part, they're RNA viruses, except for hepatitis B. In this little table, I've bolded sort of like key facts about each virus. So, for example, hepatitis A, an important fact you should remember is that the way it's transmitted is fecal oral route. So, meaning it's usually because of like drinking contaminated water or something like that. Hepatitis A doesn't contribute to chronic hepatitis either. It's the only one that really doesn't. Hepatitis B, important things to remember is that it can be spread through blood, bodily fluids, and also through sexual contact. So this is one that could be a sexually transmitted infection. And Hep B can make someone more likely to develop hepatocellular carcinoma, so liver cancer. Hep C, also through the blood, but not through sexual contact, pretty much just through blood. But once again, Hep C is in people with hepatitis C infection, 85 to 90% of patients will go on to develop chronic hepatitis. And as I said before, of all of the cases of chronic hepatitis, 40% of those are due to hepatitis C. So I remember the C in hepatitis C stands for chronic because it's like so common for someone with hepatitis C to develop chronic hepatitis. Hepatitis D, interestingly, really can't infect the liver on its own. It must also have hepatitis B around in order for hepatitis D to also infect the liver. So I like to remember hepatitis D is a dud, D for dud, because it can't infect on its own. It needs hepatitis B. It needs its buddy there in order to infect the liver. And then finally, hepatitis E, the most important thing to remember there is it's kind of similar to Hep A, and that it also is transmitted in the fecal to oral route, so mostly by drinking contaminated drinking water. Okay, so those are all our different types of hepatitis. I know a lot of viruses, but once again, the most important things to remember for each one are the bolded items that I put in that table there. Okay, let's move on to disorders of the gallbladder. Okay. So I should have put animations on this slide. I'm sorry. It looks really busy now. So cholestasis is going to be inflammation of the gallbladder. Anytime you see the prefix chole, that means bile. I kind of remember like cholesterol, which is a fat. You need bile to solubilize those fats, right? So that might help you remember that little chole prefix means bile, gallbladder. So anytime you see that chole prefix, you should think gallbladder. So cholestasis is usually due to gallstones. So like a buildup of bile and like biliary sludge inside of the gallbladder that can cause obstruction. So what is so fun is depending on where those gallstones are, there are different terminologies that look very similar, but I'm going to give you the trick to remember which gallstone is which. So first off, any time we're talking about like a stone, like a gallstone, you're going to have a suffix there that's leophasis. Oh no, I've talked too much today. Lithiasis. We got it. So that means stone. So here we have 2 different types of stones, and you can tell they're stones because they have that nice lithiasis suffix. Beautiful. So the first one is choledocholithiasis. Choledocholithiasis. So the way I remember this is this little center part, this doke kind of sounds like duck. So this is a gallstone that forms in the common bile duct. So it is actually a gallstone in the duct. So it's really blocking any bile from getting into the small intestine. You can remember because it has that duck part in it. That is in contrast to Oh my God, guys. Cholelithiasis. It's like so many letters that are the same. It's very tongue twister. Those are gallstones that actually form within the gallbladder themselves. So they actually just kind of sit inside of the gallbladder. So this diagram helps you see the difference here as well. So cholelithiasis, those are gallstones inside of the gallbladder, whereas the cholelithiasis are gallstones that are in the bile duct. I've never seen those words again the rest of my life. Why? Beautiful. Okay. So once again, uh, cholecystitis is inflammation of the gallbladder, which is usually due to gallstones blocking bile at some point in the gallbladder. So signs and symptoms of cholecystitis. So the first is epigastric pain with radiation to the shoulder, which is called Collins sign. Um, because you have this pain that feels like it's like kind of stomach, chesty, and it radiates, a lot of times this gets confused for cardiac chest pain. So just a heads up with that. Abdominal pain in the right upper quadrant, and then also something called Murphy's sign. So I'm going to show you guys a video because I think it's easier to watch someone do the examination to look for Murphy's sign than for me to try to explain it. So here we go.
Murphy's sign. Ask the patient to exhale while palpating the gallbladder area medial to the midclavicular line. Now instruct the patient to take a deep breath so the gallbladder is pushed down and against the examiner's fingertips as the lungs expand. If cholecystitis is present, the patient will experience a sharp and sudden pain, causing them to abruptly cease inhalation. This reaction is known as a positive Murphy's sign.
Here we go. So that last little part.
This reaction is cease inhalation. This reaction is known as a positive Murphy's sign.
So it's like specifically that part, the so essentially when you push on, essentially you're like making the patient breathe out, and then you're using that to push onto their gallbladder, and then they breathe in. The diaphragm is going to put more pressure on the gallbladder, and that's going to be painful, which is going to make them be like, ooh, they're going to stop breathing immediately because it's going to hurt. So a positive Murphy sign is when you have like that palpitation, and then the patient stops breathing because you're pushing on it. It's not like they have dyspnea or like trouble breathing. It's just that because it's so painful, they're like, ooh, ow. So I like that video because the guy did a nice acting of being like, ooh, ouch. So that is Murphy's sign, which once again is a classic sign or symptom. Oh, nope. Okay. There, wait, was that the last one? Yes, okay. Moving on to disorders of the pancreas, which is our last topic for this evening. We're gonna get close, we're gonna be just slightly over an hour. It's pretty good. Okay, so first is pancreatitis. So pancreatitis is inflammation of the pancreas. Keep in mind that, as I mentioned before, the pancreas has endocrine, so hormone-releasing hormones functions, as well as exocrine functions. So the exocrine functions are digestive enzymes. So in acute pancreatitis, you have inflammation of the pancreas. And that is essentially due to the fact that those digestive enzymes are digesting the pancreas itself, which is kind of terrifying. So what can cause acute pancreatitis are gallstones. So those fun guys we just talked about, alcohol abuse, abdominal trauma, like especially stabbing wounds, like stabbing the pancreas, infections, and then hypertriglyceridemia, so really high fat content. And then chronic pancreatitis is inflammation of the pancreas. Oh, there's a typo there. Leave it alone, it's fine. Inflammation of the pancreas that does not heal and leads to permanent damage of the pancreas. So acute would be like that sudden inflammation, and then chronic, we have long-term inflammation that doesn't heal and leads to permanent damage. So acute pancreatitis, once again, can be because of gallstones that are blocking the common bile duct. Because of that, the pancreas actually will not be able to secrete digestive enzymes into the small intestine. And so those digestive enzymes can back up into the pancreas and cause autodigestion, meaning like digestion of the pancreas by its own pancreatic enzymes. I'm figuring out that my spell check doesn't automatically recognize that pancreas is not a word. Okay. So some signs, classic signs and symptoms of acute pancreatitis. The first is really intense epigastric pain, which is worse when lying supine, meaning when like lying down all the way flat. So a lot of times someone with acute pancreatitis will be more likely to lie in like a fetal position because that will make the pain less bad. But if they lie flat all the way, that is going to cause worsening pain. So that's lying supine. And then there's also these two classic signs of just like that look like really horrible bruises. So the first is Cullen's sign, which is going to be discoloration around the belly button. And then Turner's sign, which is discoloration around the flanks. Both of these look like bruises, but they're not necessarily bruises. It's essentially due to those pancreatic enzymes being released and causing inflammation and bleeding within the peritoneum because of that pancreatitis. So both of those, and then also that pain that's worse when lying supine are the classic signs and symptoms of acute pancreatitis. Okay. And with that, that's going to be it. I just want to remind us of one thing here. So I said some of the causes of pancreatitis can be hypertriglyceridemia, which is actually less common in people, but is very common or is more common in dogs. So it is Thanksgiving this week. And I know my family were always like, oh, doesn't the dog want a little, turkey? Just watch out because if you give a dog a lot of fatty food, it's actually likely that they can get pancreatitis. So this is like the most common or like the most cases of pancreatitis in dogs of the year is the week of Thanksgiving. So just watch out if you have someone in your family who wants to feed your dog a little Thanksgiving turkey that you don't give them too much, don't give them any gravy or anything like that because they could get acute pancreatitis due to all those triglycerides. Okay.